Hello, my name is Timothy Orr. I am a Stony Brook Dental Anesthesia Program graduate. I finished in 2012. After I finished the program, I moved here to Austin, Texas. Right now I work all over the state of Texas, primarily in Austin. What I do is mobile dental anesthesia, and every once in a while I do cases in a surgery center type facility, but the majority of my practice is mobile. I don't teach any anesthesia disciplines, but I did get my instructor certificates in ACLS, BLS, and PALS. So I teach those courses every once in a while. The Stony Brook program has been very helpful in helping me to decide what kind of practice I want to have. I got a lot of experience in both hospital surgery, surgery center, office-based, different types of anesthesia. I was able to see how the medical anesthesiologists do it in the hospital. Dr. Epstein, how he does it, Dr. Boren, different types of airway management, different types of medication management. Couldn't have asked for more diverse training, because all these different types of anesthesia just teaches you that there's more than one way to do it. So the off-site training that we had, when I was there, we did have preoperative services, medical optimization, cardiology. We didn't round with the rapid response team when I was there, but all of those different services are very helpful. You're going to be dealing with those on a daily basis if you're treating patients every day. You kind of have to do them all at the same time when you're looking at a patient and evaluating whether or not you can treat that patient in an office setting, or if that patient's more optimal to be seen in a hospital. So you kind of do your preoperative assessment, and at the same time you do your medical optimization. You find out what information you're going to need from the physician or the cardiologist or the endocrinologist or whoever, and you go from there. And that's all part of, in my opinion, the preoperative treatment of the patient. Once you get all the information that you need, then you decide whether you proceed in an office-based setting or hospital. All these skills are extremely important, because I've always thought since residency that the most difficult part of doing office-based anesthesia is making good decisions on which patients to treat in an office and which patients should be treated in a hospital. So the more information you can get and the more effective you are at communicating with your medical colleagues, the better. Since I finished, have I been involved in any serious anesthesia emergency? Yes. I had a patient who went into pulseless VTAC. Recognized it right away, thankfully, treated it. It probably took 60 to 90 seconds to get the AED out, shock the patient, restore the patient to normal sinus rhythm with a pulse. And then everything else that happened after that was uneventful. We ended up going to the hospital and getting a cardiac workup and getting the kid evaluated, and everything seemed to be normal. But that emergency was handled quickly and efficiently, partly because I had seen so many while I was at Stony Brook, and I had seen one during an anesthesia case at Stony Brook, and I got to see how a proper code should be run by my attending, and I also got to see quite a few in responding to code blues and code T's in the hospital. I also had a few other experiences in helping to diagnose previously unknown medical conditions. Wolff-Parkinson-White. You're going to see quite a bit of tonsillar hypertrophy in little kids, and informing parents of these things that you pick up on can improve the lives of these kids. The kid who had Wolff-Parkinson-White ended up going and getting a 12 lead at the cardiologist. It was an official diagnosis. Once he saw the cardiologist, it was treated by interventional cardiology, and the mom sent me quite a few emails. I'd say 3 or 4 emails. Just so grateful that I was able to pick up just on a lead 2 of my EKG the slight variation that I saw in the EKG, and recommend that he get it looked at by a cardiologist. And even though the sudden death rate is really low. I think it's like 0.1%. It's still something that you want to know as a parent. And without the training at Stony Brook and the information I received from all my cardiology and study there, I don't know if I would have been able to pick that up. The PACU experience, also extremely helpful. You're going to do that pretty much yourself if you're working office-based for every single patient. You recover your own patients unless you have a PACU nurse that you want to bring with you, and even then you're still going to have to be responsible for recovering your patients until you can discharge them to the parent, so it's safe to be discharged. Everything you're going to learn in PACU helps you make those decisions when you're out. And the more that I talk with all my colleagues at these annual meetings and semi-annual meetings, the more I realize how extensive and thorough our training was at Stony Brook compared to other places. Naturally, everyone's going to say I'm biased because I went to Stony Brook, but I've spoken with lots of graduates, and I have a lot of graduates from other programs who work with us, and I wouldn't trade my education at Stony Brook for any other. So I hope you seriously consider Stony Brook in the future. You're going to get a lot of experience. You get to see quite a few medically complex cases, and you're going to learn anesthesia very thoroughly. And that's pretty much it. Thank you. Bye.